Hi everyone, my name is Rona. I'm a current PGY2 in internal medicine at Walter Reed for anyone who hasn't met me. And today I just wanted to create a quick video overviewing some of my shelf review slides. I hope this will be high yield for you guys. In person, this would typically involve a more interactive session. So I'm going to stop multiple times throughout this video so you have time to think. And if you have any questions about these slides, please feel free to email me at any time. So just going into question 1, we have a 50-year-old male with a history of peptic ulcer disease. He's presenting with severe abdominal pain and hypotension, and you notice rebound tenderness with guarding on your physical exam. What are you worried about at this point? So the test is trying to get you to think about peptic ulcer perforation in this patient who has a known history of peptic ulcer disease and is now presenting with these acute abdominal symptoms. So you end up getting an x-ray of the abdomen and it's not showing a clear peptic ulcer perforation, but you are noticing that the patient is still having those same physical exam signs of rebound tenderness with guarding. He's hypotensive. What should you do next? A is get a CT abdomen with IV contrast, and B is consult surgery. So the answer on UWorld here was consult surgery, and the combination of that acute abdomen with the rebound tenderness and guarding, as well as the fact that he's not necessarily hemodynamically stable, they advise that you should not delay a surgery consult for more imaging. And further, this is emphasizing that if you have an unstable patient, putting them in the CT scanner is not going to be the correct answer. And this is an x-ray image of what you might see with a perforated peptic ulcer if it is positive. The biggest buzzword here is going to be that free air under the diaphragm, which we're seeing on this image. And clinically, they might present with abdominal pain that's radiating to the back. It might also refer to the shoulder. And now continuing that theme of the multiple peptic ulcers, so now we have a 30-year-old male, multiple peptic ulcers despite treatment, an elevated serum gastrin level that's above 1,000, diarrhea and steatorrhea. Which condition are you thinking of with these buzzwords? So the answer here is going to be Zollinger-Ellison syndrome. And just to overview this condition, you have a neuroendocrine tumor which is secreting gastrin, and that increases gastric ulcer acid production, which is going to lead to those recurrent peptic ulcers and diarrhea. The diagnosis is going to be through an elevated serum gastrin level and a low fasting pH, and if you are able to localize it, then surgical tumor resection is indicated. And why is there diarrhea associated with this condition? The answer is going to be pancreatic enzyme inactivation. And then which genetic condition is this associated with? So this is part of that test question favorite, the MEN condition. So this is MEN1, which is going to be the one that's associated with pancreatic endocrine tumors, as well as pituitary adenomas and parathyroid. So parathyroid, you see here MEN1, where we have that endocrine pancreatic cancer. This is the only MEN condition that's going to have that. And then you also have the pituitary adenomas, again, the only MEN condition to have that. And then the parathyroid adenoma is shared between MEN1 and 2A. And remember this picture because we're going to come back to it in a later slide. Just to review for the other conditions, both of the MEN2 conditions, A and B, are going to have pheochromocytomas and medullary thyroid carcinomas. And then MEN2B is going to be the one associated with that marfanoid habitus and the mucosal neuromas. And how do you diagnose Zollinger-Ellison syndrome? So we already talked about that serum fasting gastrin. Just as a reference, the normal is going to be less than 100. If it's uncertain, then the next step is going to be a secretin stimulation test because normal gastric cells, which are producing gastrin, should be inhibited by the secretin. And this is just a graphic that's demonstrating the whole triad of Zollinger-Ellison syndrome. You have the pancreatic or duodenal tumors, which are secreting gastrin, that's associated with gastric hypersecretions, and multiple peptic ulcers, which are refractory to medical treatment. And this may also be presented as ulcers that are at unusual places like the jejunum. And now, going back to a previous slide, if you have thyroid cancer and high calcitonin, which cancer are you thinking of? The answer here is going to be medullary thyroid cancer, so the parafollicular C cells are going to be secreting the calcitonin. And which genetic condition was this one associated with? So this one was both MEN2A and 2B. And then this is just going back. Remember that medullary thyroid carcinoma and pheochromocytomas are both in MEN2A and 2B. And then how could medullary thyroid cancer affect calcium levels? So you may see evidence of hypocalcemia due to the increased calcitonin secretion. And the UWorld question bank actually said that you generally do not see symptoms of hyperthyroidism. And if someone has known MEN2B, then a prophylactic thyroidectomy is often performed in infancy when they're less than 1 year old. So hypocalcemia, just a review of this topic since we talked about it with our medullary thyroid cancer. It can also be associated with other electrolyte conditions like hypomagnesemia. And which EKG changes would you expect to see in a patient with hypocalcemia? So the answer here is going to be QT prolongation. And which clinical symptoms are going to be associated with hypocalcemia? So the answer here is going to be paresthesias. You're going to have some hand cramping, perioral numbness, and tetany. And now going on to another case, so just moving forward here, you have a 20-year-old female with episodic palpitations, flushing, diarrhea, and weight loss. You get a CT of the abdomen pelvis, and you find a tumor in the terminal ileum. And you get this lab that's showing an elevated 24-hour urinary 5-HIAA. What are you thinking about with that constellation of words? The answer here is going to be carcinoid syndrome. And so just as a review of carcinoid syndrome, you're going to have that episodic pounding and the flushing, the chronic diarrhea, and the weight loss. And why would you want to perform a TTE on someone who's diagnosed with carcinoid syndrome? It's to assess for tricuspid valve disease. So carcinoid syndrome, the tumor will secrete serotonin, and it's thought that this is inactivated by the lungs, but it goes to the right side of the heart, and it's going to cause these plaque-like deposits, which leads to tricuspid regurgitation. And the diagnosis is through that elevated 24-hour urinary test. And what is the treatment for carcinoid syndrome? So you're going to want to get a CT or MRI of the abdomen pelvis, surgery if you can localize something, and then octreotide is going to be a somatostatin analog, which binds and inhibits the release of serotonin. And then which nutritional deficiency is associated with carcinoid syndrome? So this is going to be niacin deficiency, and the reason is that all of the tryptophan is going to be shunted over to serotonin production. And then the symptoms of niacin deficiency, so this is going to be that triad of the diarrhea, dermatitis, and dementia. And again, it's thought that the serotonin is inactivated by the lungs, so you primarily get those right-sided heart lesions. And then just reviewing back to the topic of tricuspid regurgitation, we've already talked about one, but if you have a young person with tricuspid valve problems, which two conditions should you be thinking about? So we've already mentioned the carcinoid syndrome, and the other is going to be IV drug use, which can be associated with endocarditis. And what is the murmur for tricuspid regurgitation? And the answer for that is going to be a holosystolic murmur at the left lower sternal border.